back. With me right now is Dr. Bryce A. Johnson. He is the medical director for the Spine Health Center at Memorial Care, right at Saddleback Medical Center. Welcome, sir.
Great.
Nice to have you here today.
Thanks for having me, Ken. I appreciate it.
Yeah, it is great to have this program just right across the way. And we were talking right before we came on, and you work right with the hospital, but also you're right here across the parking lot from us here, where many of the doctors that work with Saddleback are sort of, that's kind of their base of operations, right?
Correct, yeah. I work with SEOS right here, essentially, like you said, right across from the parking lot. I've been there about 12 years, one of two spine surgeons. We now have 3 locations. We have the Laguna Woods office here.
Right.
We have an office in Irvine, and then our newest office is in Fountain Valley. And I've been one of the partners down here for just about 12 years, just over 12 years at this point now.
Well, you know, when people hear spine health, I think the first thing they probably think of is, you know, all the different complications that can happen. And, you know, you hear spine, is it paralysis, is it this kind of thing? You know, what we're kind of be talking about today, though, is really chronic back pain, am I right?
Correct. And
obviously, you're talking about along the spine, but other areas that can kind of branch out from there, am I right?
Correct, yeah. And you know, the thing with back pain or even neck pain in general is it's such a far-reaching problem. And what I mean by that is 90–95% of people at some point will have some degree of pain in the neck or back. So it's one of the most common medical problems that people experience. It becomes more common, unfortunately, as we age, as you and I probably both have experienced. And it can be quite debilitating. The good news is that most of the time it doesn't have to be.
Okay. Now, at what point in time do you go from, okay, I kind of wrenched my back because, you know, I was playing a sport, I was working on something, versus, okay, this is more of a problem. Something else happened here, and is it, does it get to the point where I need to see a specialist?
Well, so as I mentioned, most people will have some degree of back pain at some point in their life. Typically, most of that resolves within about the first 2 to 3 weeks.
Okay.
So the far majority of back pain, or really neck pain, is self-limited, not a big problem, and unfortunately, it's kind of just a process of life, for lack of a better word. So typically, when you're thinking about kind of taking the next step in evaluation, it would be times where that pain is so severe that you're very, very debilitated. It's been present for 2–3 weeks and just is not getting better. Or the third thing, which is really the least common, are if you have a red flag. So I'm having weakness. I have a past medical history of cancer or something that could actually be masking itself as a different cause. But the far majority of the time, it's not any one of those things. And the reason I always bring that up is because those are the conditions that patients are most fearful of when we're talking about non-operative back troubles.
Right.
Do I have cancer? Do I have an infection? My friend had some back pain, and they were diagnosed shortly thereafter with cancer, and now they're no longer with us. Most of the time, that's not the case, though. Okay,
now, are you talking about, you know, when you're talking about chronic back pain, is it caused, I mean, there's a lot of causes. There's, like I said, you wrenched your back doing something, whatever it might be, but there's also degenerative pain or degenerative of the discs or something that's causing something, I would think, a little bit harder to treat, a little more serious, because if someone comes in to you saying, yeah, you know, I picked up a bag of something and did something on my back, it's like, okay, we know why this happened. But when you have something degenerative there, that's a little bit more difficult to treat, right?
It can be more difficult to treat. It can also be more difficult to diagnose. And what I mean is when we hit the age of 50, 50% of people will have some change, so some abnormality on their x-ray, on their MRI scan or CT scan. And so the challenge becomes, hey, I lifted something funny, having some back pain for a couple weeks, and oh, my x-ray shows these degenerative changes. The trouble is drawing that correlation between both of those issues. Because even with degenerative changes, you might have just kind of your standard strain or sprain, which you've alluded to. And it's also possible that people can have degenerative changes on their x-rays, on their MRI scans, on their CT scans, and really not have many symptoms at all. And why that's really important for people to know is because those degenerative changes occasionally, with continued pain, can lead to surgery. Now, surgery can be very helpful in the right cases. In other cases, though, you have to be careful because spine surgery also, as you alluded to earlier, comes with some potential downsides,
Right,
even beyond just not getting better from the surgery, meaning some potential complications. So it's important for patients to know, and what I always try to explain to my patients is that the pain that they're experiencing at times is correlated to what we're seeing on their imaging, and at times it's not. And I think the biggest challenge for a spine surgeon is to actually tie those two things together when and if the patient gets to the point where they need something surgical. Now, once again, 90%, 95% of people who have some degree of back pain at their life won't actually ever need a surgery to fix it. But those are the considerations that I'm always discussing with my patients as we talk through problems.
So when they do need surgery, is at that point when, you know, something that's non-cancerous, you're now looking at something about a disc or something that's out of alignment more serious than, again, hey, give it a couple weeks and, you know, that type of thing?
Correct. Yeah, surgery really, for the majority of what we're talking about here, should be considered a last resort.
Okay.
And patients will come in and they'll say that themselves, and I can't agree more with them. There are times where you have to move surgery earlier, and that's with some of the, what we call red flags, some of the things we discussed earlier, the neurological problems, the cancer problems. But for most of these degenerative problems, it should be considered a last resort. Then, when do you get to that point as a patient? Well, most of the time, these cases are what we call elective. So the patient really gets to choose when they've had enough, when they've had enough pain, when the other treatments have failed them enough. And for certain patients, they get to that point very early on. For certain other patients, they really never get to that point because they're able to modify their lifestyle and they're able to do what they want to do for the most part without pursuing surgery. Ultimately, that's what surgery is trying to do, is it's trying to get people back to doing what they want to do.
And I guess in some cases, you know, people, especially nowadays, a lot of talk about pain medications and people don't want to be on them anymore. So it's how much they can tolerate and get through it.
Yeah.
So obviously there are different kinds of surgeries, but someone comes in, gets a surgery done, and what's the recovery time? Can it be a week, and it might have to be several months?
And Ken, that's exactly right. Depending on the surgery, it can vary quite a bit. So I always like to talk to patients about knee surgery because a lot of people are familiar with meniscus surgery and total knee replacements and that disparate recovery between the two of those. Similar concept with spine surgery. So you could have just a small little microdiscectomy or microlaminectomy. So just a time where I go in and just clean out the nerves. That recovery can be as quick as 2, 3, maybe 4 weeks. People are back doing everything they want. Up to bigger fusion procedures. So that's where people need rods and screws for some of the instability you talked about. That can be a couple months. Into some procedures that actually really people can improve up to a year after surgery because of the big problem that they needed to have fixed in the first place. That's really those big scoliosis surgeries. The ones that tend to be a lot less common and the ones that people tend to really be a lot more disabled before they get to that point.
What about, you hear now, you know, sometimes you hear this in radio ads and things like that, that the disc can be restored through non-invasive measures. Is that possible?
It's not quite possible yet. There's definitely a lot of active research in that direction when we're talking about chronic back pain, and it somewhat ties into what we had talked about with that amount of degeneration you can see in people even without symptoms. I think that's a huge area where over the next 10 to 20 years, we're going to see a big difference. Now, the irony there is I've been saying that for the 10 years I've been practicing the same number, so maybe I should change that a little bit. But in reality, that's probably going to be the biggest change that we'll see, the biggest development that we'll see kind of in this generation of spine care. And that's most likely going to open up a huge door to a lot of people who not only are surgical candidates now so that they wouldn't need surgery in the future, but there's also a big group of people who are at an in-between. They're not good enough that they can do what they want. They're not bad enough that they want to pursue surgery. And that's where this treatment likely can benefit people a lot once we get to the point where it's really available.
What about keeping your spine healthy beyond the usual, you know, lift with your legs, not with your back, you know, those kinds of age-old suggestions? What are some of the things that people can do? And I would assume this is beyond if somebody has something hereditary that's degenerative that no matter what they do. So what can people do?
Well, we'll go back to, I think it was Benjamin Franklin that said an ounce of prevention is worth a pound of cure. Realistically, that's what we should all be striving for. And the best things to do really are a lot of the same things you'll hear from your primary care physician just about being healthy in general. Non-impact aerobic exercise, weight management. For the spine, some exercises that are really good are swimming or bike riding.
Okay.
So
bike riding, I never would have thought that.
Yeah, bike riding is
swimming I could see. But
swimming is good. Now the one downside I will say, Ken, for swimming is people who have back problems oftentimes have neck problems also.
Okay.
So sometimes what they need to do is get a swim snorkel so that they aren't doing the constant turning that's required to breathe. But that can be a great exercise for the back. Biking is a great one, especially recumbent biking.
Okay.
And then core strengthening. So the core muscles are essentially your stomach muscles, your back muscles, your pelvic muscles. And things like yoga and Pilates are great exercises to keep those strong. And the idea there is that strong core will offload the rest of the spine. Now, what it's not going to do is it's not going to change what we see on x-rays. So x-rays will still continue to degenerate. MRIs can still continue to degenerate. But what stabilizing that core does is it offloads, it takes the pressure off that lower back, and it minimizes the chance of symptoms. So there's one bit of advice I could give to anyone out there who says, geez, you know, I really don't want to have a problem with my back, or I want to minimize that. Start some core exercises. And the best part of making that recommendation, especially when I have a husband and wife, is usually that interaction is the wife looks at the husband and just kind of starts nodding her head and says, I've told you to do this for a long time. And the husband just shakes his head and says, I know you have.
Yeah.
I know you have.
One last question.
Yeah.
What if someone is just working out in their yard, you know, they pick up a bag of fertilizer or whatever it is, and they do wrench their back a little bit. And, you know, they're not totally debilitated, but ice pack, heat pack, what?
That's a great question. And I get
That's
that question all the time.
It's always the answer. Do you ice it, do you heat it?
Exactly.
You know?
That's the universal question.
Yeah.
And typically with that sort of an injury, you want to ice it.
Okay.
Just like you would if you twisted your ankle. So you start with ice. Now, where that gets a little bit confusing for patients sometimes is they'll come in or they'll see a physical therapist, which you can actually hear, if you want, go to see a physical therapist for a couple visits before seeing a physician. And the physician, the physical therapist will actually start with some heat.
Okay.
And it confuses patients a bit. Well, the reason the therapist does that is much like you would warm up before you're going to go for a run. They want to warm the muscles up before they do what they need to do to help treat you. But you yourself as a patient, you're out gardening, you bend over to pick up that flower that you've really been wanting to prune for a while. And now what happens is your back flares up. Rest, ice to decrease the inflammation. And then if it's all right with your doctor, anti-inflammatory medications. They can be absolutely essential and a fabulous treatment for this. And you somewhat touched on that earlier in terms of the narcotic usage that's done for back pain. Anti-inflammatories, as long as you can take them, and you can take them comfortably and without side effects and without any sort of contraindications, reasons not to take them, they are an absolute great medication.
Okay, so that would be ibuprofen or naproxen or something like that.
Exactly. Naproxen, ibuprofen, Advil,
Any
Aleve.
one works better than the others?
They all work equally well. They all work equally well.
Okay. All right. Great advice. Doctor, thank you very much.
Thank you for having me, Ken. I appreciate it.
You can find Dr. Johnson over at the Saddleback Spine Health Center. And for more information, you can go to memorialcare.org/SB Spine. And the number is 949-837-4500. And, you know, take care of your back, right?
Exactly. Exactly.
Good to have you on. We'll see you again.
Ken. I appreciate it.
Take care. We'll be right back.